longer in the anxiety disorder chapter of the new DSM-5. This OCD now has its own chapter. Okay? There's probably some OCD writer. Anyhow, by definition, what is one of these? Okay, the terms obsession versus compulsion. Okay, which is the recurrent thought? Obsession. So I'm obsessed with a certain idea or thought that comes just in my mind and I just can't shake it. Okay, the obsession. Whereas a compulsion involves the repetitive behavior, sometimes described as ritualistic behavior, that the person feels compelled to perform. Okay, and usually the compulsive behavior is in response to the obsession. So if you have somebody that has a germ phobia, they're obsessed with, everything's germy and, look at this room, there's junk on the floor, there's Cheerio. I think I picked this up yesterday, here actually. There's Cheerio on the desk, germy, if people are coughing and sneezing or whatever, your compulsive behavior may be to sanitize everything, wipe all the tabletops and so on. Okay, you got it. Engaging in the compulsive behavior, okay, is going to serve to decrease the anxiety, okay? Because it gives you kind of a sense of I'm in charge, I'm in control, I can handle this. Okay? And because the actual behavior, the compulsive behavior serves to decrease anxiety, if somebody tries to interrupt you while you're doing compulsive behavior, you're probably going to have your anxiety levels going to skyrocket, and you may be kind of try to push, get the person to go, leave me alone. It's kind of the response. Okay. Once a person is already engaged in the ritualistic compulsive behavior, they're going to have a great deal of difficulty stopping or controlling the behavior, hence its emotion. Even though they may be intellectually aware that the ritual is kind of unlogical or unreasonable. Okay. Symptoms of OCD are going to vary. You can have mild intensity to very extreme intensity. Mild intensity OCD is actually conducive to many occupations like nursing, medicine, accounting, fine precision measuring, in fact, we encourage, you in nursing school, we have the X number of rights of med administration that you're supposed to be following. We want a nurse that's a little bit obsessive compulsive, that's taking care of you, to make sure they're giving you the right medication at the right time and so on, and that the right test is being performed on you, etc. Okay? So that would be the mild version. Okay? Do any of you have the mild version of OCD? Probably a lot of you do. Okay. All right. Do any of you have a little bit of worry or excessive worry about like being late or oversleeping in the morning, like on a clinical day in particular? Okay.
And then you wake up
and then you still wake up so just on your own without even needing before the alarm clock goes up. Yeah. Do any of you set more than one alarms at night? Oh, a lot of you do. Okay. Do any of you just have one alarm? Check it and to make sure you set AM, not PM, because there was once, 10 years ago, that you accidentally had PM going on. Okay. All right, you get the idea. Okay. Now, if somebody were to interrupt you, like when you're setting your alarm, or making sure both of them are set at the same time, opposite ends of the room or whatever, but somebody said, that's ridiculous, don't do that, okay? What is your response going to be?
I would sleep better knowing that.
That's fine.
I would sleep better knowing I checked it.
Yeah. So that you're going to be calm. Yeah. And just like, just like, humor me, ignore it. Just get out of here if this bothers you to watch movies. Go on. Leave me alone. It's not hurting anybody, right? And the severe forms, the OCD can get to the point where, or it becomes severe if the behaviors and the thoughts get to the point that it's interfering with your social and occupational functioning. A few years back, they were advertising one of the SSRIs, probably Luvox or something that they use that does have FDA approval for treating OCD. And they showed this guy in the restroom at work. kind of large restroom. They had very small ceramic tiles, like on the wall, okay, and on the ceiling. And the person's OCD was counting, okay? And that's a pretty common one, actually. So, I mean, even with big ceiling tiles. Now, I don't want to distract your lecture, but I mean, if you started counting them, you know, and then, okay, these are probably a little bit easier to do than the really tiny, 2-inch square ones or whatever. But you could just imagine this person getting lost in the count, especially with the small tiles, to the point that he probably was going to end up spending a long time in the bathroom, more than would be warranted, because he's not going to let himself go until that happens, until he gets the right count. He may have to double check the count. So that's the point where it needs to be treated. It's interfering with social and occupational functioning. And basically, when it becomes a quality of life issue, you know, for the person. Post-traumatic stress disorder, PTSD, is written about, or has been written about extensively, actually probably ever since, I think it was right around the Vietnam War, where we've had it. The condition has been around for a long time, but they called it different things, like in different wars, like in World War I think they called it shell shock. Or sometimes they'll even just call it kind of the lay public name, just say, oh, the person had a nervous breakdown, when they're in the military or whatever that is supposed to mean. Okay. But in terms of PTSD, okay, this is also in a new chapter of this only in DSM-5 under trauma and stress-related disorders. Diagnostic criteria of PTSD. I know you have read about it in your book. Your ATI book does really actually a very nice job of summarizing acute stress disorder versus post-traumatic stress disorder. And I need to look up the page because I really want to point that out to you. So let me find it quickly. Let me find it probably around page 88, 890, something like that, I think. It's going to be on page 90. We have acute stress disorder. Where's post? Do you have the correct? You do have the correct edition. I think
They're together.
Where's? Oh yeah, thank you. Thank you, sister. I'm looking. That was a goofy title. I'll blame the book. But yeah, page 90. They differentiate between acute stress disorder versus PTSD. Okay. And, you know, basically, the signs and symptoms are identical for both. Okay, they're the same. But we call it acute stress disorder if, in terms of the difference is on the onset and duration, when it starts. So if we call it acute stress disorder, it happens basically after the exposure to the trauma. Whereas it's called post-traumatic stress disorder, I think it's a month. It starts a month after. Okay? So, you know, for you to realize there is actually technically a difference in the two, but it just has to do with it in terms of the onset. Could all of you in this room be potential candidates for developing acute and PTSD?
Yes.
Absolutely. Okay. I mean, PTSD happens to normal individuals, okay, who have been exposed to actual or threatened death or serious injury or sexual violence. Either it's happened to you, or it's happening to you right now, or you're like the eyewitness. You're right there when it's happening to someone else. So you can be traumatized because of that. And then afterwards, what do you know symptom-wise about the person's response when they've been exposed or experienced this overwhelming stressor?
Aggressive, abusive.
Oh, sometimes that can happen in terms of the anger being really out of control. Yeah.
Is it like the shutdown, like the, you know, they isolate themselves and
Yes, you're going to see that more
depression,
often, where they're going to kind of go off to the hills and be alone and kind of close everybody off. You know, they may get to work every day, but the things, you know, when they get back home after work, they're not themselves. They have no interest in, you know, social things, recreational things, things that used to bring them pleasure. They just kind of check out, you know, away from those things. People that knew them before the trauma would say he or she is just not himself, or he's not himself, she's not herself, something, she's never, she really is really having a lot of stress, okay? What happens at nighttime? A lot of times they're not sleeping because they're having these recurring, very vivid nightmares and stuff. And that can actually even happen during the daytime, during the waking state. They may be triggered, and the senses are very powerful triggers. Sense of smell, huge, powerful trigger. A person may smell something, maybe, God forbid, let's say a person was sexually traumatized, and let's say it happened early in May when the grass had been just cut with, kind of that springtime grass smell the first time. Okay, then whenever they smell grass, newly mown grass, that may be a real powerful trigger. Okay, or smoke may be a trigger if there was smoke in the environment. If the person was in combat, and they smelled smoke, or they saw a lot of light, flashing of lights and stuff, or hearing sound. When I worked in the VA psych ER, I would have vets that would be triggered by hearing helicopters. That might be like a flight for life chopper, but in their mind they were back in Vietnam again. People say, well, I was out for the family on a Sunday afternoon drive, in the countryside, watching the San Joaquin. And all of a sudden I heard this helicopter, and I ordered the whole family out of the car and into the ditch. And then as we're laying in the ditch, and the kids are looking at me a little scared, like, it was like, oh my God, it's like I'm not in Vietnam, there's not immediate danger, it's a fight for life helicopter, but it's like that, it's like a snapping kind of behavior. And if they're having trouble coping with day-to-day living and having trouble sleeping, what do they turn to a lot of times? Substances, drug or alcohol. A lot of times you'll see that occur. Okay, so they're trying to avoid the stimuli, they're trying to avoid numb out the feelings and kind of escape. That's classic PTSD. And acute stress disorder, we just talked about basically the same symptoms, but it occurs early on in the stages. Interesting. I know. When we look at nursing interventions to help people with anxiety disorders, with OCD, with PTSD, etc., keep in mind that mostly we're dealing with individuals on an outpatient basis. The outpatient therapist may recommend relaxation, imagery, focusing on breath, focusing on being in a relaxing, calm place, basically systematically getting rid of the pathways, macheting the pathways that do that automatic stress trigger. And we replace those with relaxation and imagery kind of techniques. We already talked about the focus or the purpose served by repetitive behaviors in OCD in terms of decreasing anxiety levels. In terms of meta-administration and the types of meds, if you pull out your Tiny Townsend, flip to page 4, and you'll see, a little bit after 406. Let me look. 406, that's where this chapter starts. Actually, go to 408, okay? And in terms of the medications that I want you to know, on 408, what is the chemical class? Benzos, the benzodiazepines. I want you to know all the meds on 408 and all the first med on 409. So I want you to know Xanax, Librium, Klonopin, Transine, Valium, and Ativan. Okay. And what do you know about benzos?
They're very addictive.
That they can be very, very addictive. Okay. And addiction or dependency can develop with these meds. Okay. Therefore, we strongly recommend a person that has an addictive personality, such as they've been treated or they could use some treatment for alcohol or drug abuse, either presently or they've had treatment in the past. These are individuals that are poor candidates, at least for long-term maintenance on an anti-anxiety med, on a benzo type of anti-anxiety med, because we're concerned about cross-dependency occurring, where the person's switching their dependency from alcohol onto the prescribed Xanax. Then on 413, we have a non-benzo called buspar. And this is also used as an anti-anxiety agent. This medication is not a benzo, therefore it's not addictive. So if you have somebody that has a chemical dependency history that is needing longer-term anti-anxiety meds, this may be the med. This is one of the meds that might be used. Okay. The deal with buspar is going to take 2 to 3 weeks for it to kick in terms of effectiveness. If you have somebody that's acutely anxious right here, right now, they may not be able to tolerate the level of anxiety long enough for the buspar to kick in. Okay? So for in acute, like ER settings, probably going to give the person like a benzodiazepine to calm the symptoms. Okay, now we're going to shift gears. Wait, before we shift gears, the benzos, we teach the patient not to quit taking the drug abruptly, as according to your care plan book, page 415, your care plan book says it actually can be life-threatening. You're going to definitely have rebound anxiety, but you're going on to say it can be life-threatening. I'm not sure what is it about.
I read it's because a benzo, so it brings you down, right? So it's a CNS depressant.
Right.
So if you rapidly come off of it, then it rapidly stimulates you, and it then in turn is seeming a stimulant at an adverse effect.
Okay.
You know, making you too high, make everything go, making your blood shunt to places it shouldn't, making,
that kind of
you
makes
know,
sense.
and then it all goes to your brain. And
Yeah.
So then that's why you like titrate them off it, because that better.
Probably is it.
Yeah.
All right, that seems like a reasonable explanation.
There's a really good video on Simple Nursing about it.
What's that?
There's a really good video about that. I watched about it.
I think you're probably right. I'm okay. Well, anyhow, you got the idea too. There's the whole guideline there. Under doctor's supervision. Now, next slide, we're going to talk about somatic symptom disorders. Don't anxiety disorders. Somatic symptom disorders. This is a new chapter in the DSM-5. The common feature of these disorders is the prominence of somatic or physical symptoms associated with significant distress and impairment. And under this umbrella of somatic symptom disorders, the first disorder is something actually called somatic symptom disorder. And basically, in order to make this diagnosis, the person has to have one or more body symptoms or somatic symptoms that are distressing to the person or result in significant disruption of their daily life. So they have to have one or more somatic symptoms that are either distressing or result in significant disruption in a person's daily life. Okay? And basically, another characteristic of somatic symptom disorder is fear. The person's going to fear the medical significance of the physical symptom, okay? Where they're spending just a disproportionate amount of time thinking about what it is that's physically wrong with them. They have high anxiety, regarding the physical symptom. I don't know if you can help us or not, but I cannot get an internet connection, and they're aware of this problem. I can't get an internet at all. I'm just doing this for each one. Anyhow, I'll let you work your wonders. I'm going to continue lecturing. All right, so most individuals that are hypochondriacs, okay, are now classified as having a somatic symptom disorder. However, a minority of people that have this disorder might be considered to have the next thing on your slide, which is illness anxiety disorder. Okay, but in general, think of somatic symptom disorder usually being Are you familiar with that word? You're a hypochondriac? Okay, a hypochondriac is sure, like they have they have a headache, and so they're sure that this is not the ordinary headache. I think I'm gonna, it's probably a brain tumor.
They're always
Okay.
sick, something's always wrong.
Think of someone who's always on like WebMD, like heavy like symptoms and diagnosing themselves.
Yeah, it's like they're just really focused on it, but they usually blow it out of proportion. Yes, that's a good example. Yeah, they're always having their WebMD kind of like, and it happens a little bit in nursing school, where you learn a little bit of knowledge can be kind of dangerous at times, You wake up in the morning, maybe you've slept on your arm, so your arm is kind of tingly, but think, oh my gosh, I hope I don't have MS. Whatever. Yeah, okay, you got to get it. Illness anxiety disorder involves being preoccupied. It's similar to the first one. This preoccupation with having or acquiring a serious illness. Either you have it or you might be getting it. Okay? Somatic symptoms with this disorder, though, are not present, or if they happen to be present, are very mild in intensity. Okay? But the individual tends to have high health anxiety, health-related anxiety, and then will, continually, repeatedly check their body, to kind of do this body assessment, scan, kind of looking, is my head okay? They're kind of constantly focusing on checking for signs and symptoms of illness. And in order to make that diagnosis, the person has to have this illness preoccupation for at least 6 months. Okay. So it's not something that's kind of fleeting, it's something that's been going on for a while. The third thing on your PowerPoint should be conversion disorder, am I right? Mm-hmm. Yeah. Conversion disorder, okay, involves one or more symptoms where the person has an alteration in their sensory or motor functioning. The different types of conversion disorder include like conversion paralysis. The classic example of conversion paralysis is, okay, a guy wakes up in the morning and tries to get out of bed, he falls to the floor. It's like he's paralyzed from his waist down. Okay, and so let's say I shut the whole thing down and try to re-log in. Oh, yes, sorry. Hearing loss.
That's my first, that's which one, remember?
Okay, I know, that's, yeah. Oh, you just had it up? It doesn't like me either. I always use keyboard. This is the first day I've ever trouble doing it. Yeah, so it was looking for the browser because I didn't find it. Anyhow, so let's say the fiance comes over to the house that morning. She's not sleeping. Okay, she finds him laying by his bed or whatever. She said, "What happened?" He said, "I don't know. I just can't walk this morning." And she said, "What? You can't walk? Well, we need to, get you to the car or call 911 or something to get you medically evaluated." And, basically, when they get the person, are we good? Thank you.
It's down, and I have the screen open right now, but it will just, your slide should be down. You'll have
Okay, all right. Thank you so much. So anyhow, what happens, I'm not going to do it today, I'm not going to spend time at this point. But I appreciate you. So what happens is, when they get to the person, to the ER or whatever, you have them neurologically evaluated, the symptom, basically is not explained by any neurological disease. They can't find anything wrong with the person. There's a symptom called labelle indifference. It's a French term, labelle. New word, D-E-L-L-E, then the word indifference, okay, labelle indifference. This phenomena basically has been associated with conversion disorder, which is kind of like, oh, no big deal. You know, like most of you, most of us, if we woke up and couldn't walk, we would be like, oh my gosh, emergency, I need help, okay? But with somebody that has a conversion disorder, a lot of times, their response is kind of like, oh, well, I couldn't walk this morning. Kind of like, no big deal, okay? That's the bill response, okay? And there's just dispute. The new DSM-5 says, even though labella indifference, this phenomena has been associated with conversion disorder, they say it's not specific for conversion disorder. It can happen with other conditions, so it should not be used as one of the diagnostic criteria. I'm here to tell you, I think it's still to use as one of the diagnostic criteria. So for our purposes, we're going to still use it.
It's like, is it in their head?
It is in their head.
My very first med-surg patient had
It is.
conversion disorder.
Yeah.
Yeah.
And here's the deal. When you think of the body and mind being really connected, there's times when the body is going to symptomatically exhibit or take on psychological issues. There's other times when the mind's going to take over the body stuff. So upon further exploration, well, we can't find anything wrong with you. We had our top neurologist on the case. We've done our CT scan, MRI, whatever they do to rule out paralysis. Everything's normal, coming back normal. So, well, the good news is we're not finding anything neurological, that we can attribute to this. But being that the body and mind are so closely connected, is there anything that you can, what else is going on in your life right now, that may be causing some stress, whether you're aware of it or not. Or the guy, well, nothing really. The fiance said, yes, there is. We're supposed to be getting married in 3 weeks, Okay, if you can't walk, you may not be able to walk down the aisle. To hear the ambivalence about, kind of, sometimes people get cold feet before they get married. I mean, some of those jitters are pretty normal, but it gets to the point that you're not walking. You'll also see other versions of conversion disorder. You can have conversion like blindness, like if a person's been an eyewitness to something traumatic that happened. The closer you get to the court date, the person all of a sudden goes to the ophthalmologist, I just can't see at all. Well, you're the eyewitness. What do you mean you can't see? Well, when did you start having visual problems? Well, when they were served with the subpoena that they had to go to court to testify as the eyewitness, probably. You can have conversion swallowing symptoms, speech symptoms, mixed symptoms, etc. Okay, you've got the idea.
I've heard of on your wedding day, your left hand will be paralyzed, they can't move their left hand.
Yeah, well, I think sometimes your whole body is kind of, oh my gosh, what am I doing? I mean, I think those jitters kind of do happen sometimes. I remember on my wedding, I was 21 when we got married. I was pretty young. I thought I was good. And I remember getting ready to walk down the aisle at St. John's and Creighton Campus, which is a huge aisle. And I do not like to be the center of attention at all. And so they're playing trumpeters volunteer. We had trumpeters and organ. It was beautiful, beautiful music. And it was going, and it was like, I'm kind of frozen, like, oh my gosh. And I looked at my mother, my parents were walking down, and said, I don't know if I can do this, or I can go through it. My mother said, you certainly will. I certainly will, That's usually not her personality. And then the dear neighbor, who was kind of, we didn't call her attendance, but she was kind of personal. Mrs. Sherman, she said, Marcel, I use her Marcel. She said, Marcel. She was like Marcel. She said, Marcel, and she was calming, so I could walk down the aisle. Yeah, my hand was okay, but my whole body. It was like, I don't know, what have I done? I'm too young, I think, maybe. I don't know. Okay. All right, so that's conversion disorder. Body dysmorphic disorder. Whenever I do this kind of lecture, I always think of Michael Jackson. It involves, God bless his soul. It's characterized by the exaggerated belief that your body is deformed or defective in some specific way. When the person looks in the mirror, they see facial flaws. My eyes are too far apart, or they're too close together. One ear is higher than the other. Males, will look at and say, oh, they look at their hairline, I'm losing my hair, or eyebrows, I have unibrows, or, we can look in the mirror and most of us can find some facial flaw, or something wrong, okay? My teeth are crooked, my smile is goofy, my teeth aren't quite, all those things. But the deal with body dysmorphic disorder is then the person usually ends up consulting plastic surgeons, dermatologists, etc., and may undergo unnecessary surgical procedures in order to sort of correct or try to correct these flaws. Okay, those are somatic symptom disorders. Then we have sleep-wake cycle disorders. I'm going to do these quickly. I just want you to have heard of them once. We have insomnia, where the person has difficulty falling asleep or difficulty staying asleep. Therefore, they're going to have sleep quality kind of concerns. There's hypersomnolence disorder, where the person seems to need an excessive amount of sleep, okay? And when they wake up, they may experience something called sleep inertia, where they're just not functioning, for the first hour or two when they wake up. Probably some of us can do it today. And then there's something called narcolepsy. What do you know about narcolepsy? What does a person have?
Sleep suddenly.
Sleep attacks. Now, mid-sentence, all of a sudden they're asleep. In fact, if you ever see this clinically, you at first think, you're putting me on, right? This really isn't happening. No, they're not. They really are a sound asleep, okay? Generally, with narcolepsy is going to produce a period of what they call cataplexy. I've heard that once. What cataplexy involves, it involves brief episodes of sudden bilateral loss of muscle tone, okay? And it's usually precipitated by emotions such as laughing or joking. The person's laughing, joking, all of a sudden sleeping, losing muscle control, okay? However, during the actual cataplexy, when they're losing muscle control, the person is consciously aware and alert. They're awake during the cataplexy when they're losing the muscle tone. FYI once. Okay. Then we're going to shift gears and talk a little bit about dissociative disorders. According to DSM-5, the dissociative disorder is characterized by a disruption in the normal integration of consciousness, so caused by a disruption in the normal integration of consciousness. And memory and sense of identity and emotional reaction and one's perception all become kind of messed up in this dissociative state. Dissociation and dissociative responses on the PowerPoint are considered a defense mechanism to protect the individual's ego from overwhelming anxiety. And when you look at, in terms of the specific, next slide, in terms of the specific dissociative disorders, we have something called dissociative identity disorder, DID, also formerly known as multiple personalities. Like Three Faces of Eve, Sybil, some popular movies and stuff have portrayed these individuals. With dissociative identity disorder, the person has two or more personalities within themselves, at least two or more distinct personalities. And historically, the person that develops DID, I want you to write this down and start, somebody that has DID usually is going to have a history of physical, psychological, or sexual abuse. They have a history of physical, psychological, or sexual abuse. The abuse episodes usually are repeated episodes and are very severe. And typically they're done, the person's being victimized by somebody they know. It's not as random. Usually physical, psychological, or sexual abuse, the episodes or occurrences are usually repeated. It's not a one-time thing. And the level of the abuse is usually quite severe. And then there's something called dissociative amnesia, which involves an inability to recall important personal information that is usually traumatic or stressful in nature. So the inability to recall important personal information that is usually traumatic or very stressful in nature. And with dissociative states, or dissociative amnesia, the underlying defense mechanism involved is repression. There's no conscious awareness of this personal information. So repression is the underlying defense mechanism. Then we have something called depersonalization disorder, or depersonalization / derealization, and the word derealization, because there's both depersonalization and derealization, which is characterized by persistent or recurrent depersonalization experiences, okay? So with depersonalization, the person experiences the sense of unreality about body parts belonging to them or being attached. Or sometimes there's even the sense of total detachment from your mind, from yourself, from your body. So if something feels not real or in some way detached. Okay? And then there's also derealization in the same type of disorder. With derealization, though, the person experiences the sense of unreality or detachment from their surroundings. You know, they may, like walk into their house and, they've been told, this is the house you grew up in, and, I have a little bit of awareness, but for the most part, it's just, people say this is my room and my bedroom and our living room, and it feels kind of unreal. I just have this real foggy feeling, it's unreal, it's kind of distorted, it just doesn't seem right. That's the derealization. So I have heard of those ones. Okay. Nursing considerations, how are you going to do that? I want to add one more piece of information, just put nursing interventions or nursing considerations. When a person has a dissociative disorder, any of these above, in general, we're going to use supportive treatment. In addition, if you have somebody that has DID, the multiple personalities, you need to be very aware that if they're psychiatrically hospitalized, it's usually a result of one of the subpersonalities being suicidal or homicidal and at risk for harming self or other people. Okay? The other thing to tell you about DID is it requires very, very skilled and specialized training in order to treat somebody with DID in the outpatient setting. This is not something that one of the staff nurses is going to be comfortable dealing with. And there's many psychiatrists that probably aren't that comfortable dealing with something as DID. So just keep in mind that it requires years of outpatient treatment with a therapist that has specialized knowledge and training about how to treat and help to reintegrate those personalities into the whole again, the whole person, the person's Note, though, that people that have DID or any of these dissociative disorders may end up in non-psychiatric settings. You may see these individuals in the non-psych areas, you know, in the primary care practice offices and so on. So just to be aware that that exists. All right. I think we are done with this lecture. Again, reminder about taking the ATI practice test. And again, you or no, you will be successful.